Hello, my name is Priscilla, and I work for the California Orthopaedic Association. I want to thank you for joining us for this lunchtime webinar entitled What's New in Orthopedics 2018 Medicare. This webinar will last roughly 45 minutes, and we will conclude with questions and answers. At this time, I do ask all participants to mute yourself if you haven't already done so. At the end, you can unmute yourself to ask a question. In the left-hand panel, under the Handout tab, we have included a copy of the PowerPoint presentation with the live links that will be mentioned later on today, as well as a handout version of the presentation for note-taking. Lastly, we added 2 other resources with information about the topic today, including an article from the Medical Economics Journal and another from the CPT Assistant Bulletin. So now it's my turn to introduce you to the presenter, Noridian Medical Director, Dr. Arthur Lervy. Dr. Lervy spent many years as an endocrinologist in Beverly Hills. Dr. Lervy also actively is involved with the California Medical Association and the American Medical Association as a delegate and a frequent contributor to the California Orthopaedic Association. He has been a past hospital chief of staff and serves on many boards and several committees, including American Association of the Clinical Endocrinologists. He is currently a medical director at the Noridian Healthcare Solution, where he administers the medical programs in California, Nevada, Hawaii, and other outer islands. Now I will turn it over to you, Dr. Lervy.
Thank you, and good afternoon to all the physicians who are listening from the California Orthopaedic Association and their staffs. And I hope you're having a good afternoon. There'll be time for questions answered, for answers to questions a little later. Let's start. This is the standard disclaimer that I have no conflict of interest in anything I'm talking about, and to remind you that the healthcare world is changing.
Hello? I have a feeling we're not in Kansas anymore.
And of course we're not. We're going to talk about what is changing this year, or likely to change, because we're in the process of changing and the year isn't totally over yet. We're going to talk about what's not likely to change, good and bad, a little bit about E&M documentation that affects orthopedists. We'll talk about chart reviews, denials, what we are reviewing, particularly what we're reviewing that affects orthopedic surgeons, and a brief look at the future of healthcare in the last few slides. So let's talk a few slides about the MACRA MIPS program, the Medicare Access and CHIP Authorization Program, which was in 2015. And among the things it did, if you recall, got rid of that horrible SGR, Sustainable Growth Rate, and allows us to get a little bit more money every year instead of being knocked down. But it also created a situation whereby the various incentive programs we put together and would affect us with various increases or decreases depending on how well we did on the incentive programs. You could either be a member of MIPS or be an alternative payment program that was approved by CMS. And so starting next year, in 2019, actually not in 2018, they're going to go into that program unless life changes, but it's unlikely to change because the program was passed by a predominantly Republican Congress, and there still is one. But those who might not be affected by MIPS or the APM are those who, exceptions are doctors who are billing the first year, because much of MIPS is based on what you did the last 2 years before the year it begins. It's also an exception are doctors who in 2018 will be collecting or billing less than $90,000 to Medicare or seeing less than 200 Medicare patients. And that might include a number of pediatric orthopedics, might include a number of orthopedic surgeons who deal a great deal with sports medicine or younger people who aren't on Medicare. In addition, if you are in a qualified alternative payment model, which we won't discuss today, you're also excluded from the MIPS program, but you will get an automatic 5% increase if you're in it every year. So let's move on. In the end of this year, you can, if you submit one item few times before the end of the year, there'll be no loss. If you did a lot more, if you participated for 3 months or a year, you can get up to 4% increase in 2019 based on what you do in 2017. And what you do in 2018 will affect what you get paid in 2020 in terms of the increase or decrease based on what they consider incentive. Remember, anything done before the end of the year, you won't have a penalty. In 2018, you can have a greater income from Medicare or see more patients and not have to be in the whole program. Rather than spend more time on it, because there's other things more important, and I know that the Orthopaedic Association has done this many times, is just give you the website where all the information you want is there. And the website is www.cms.gov/Medicare/quality-payment-program/resource library. That will give you a great deal. If you go up to the qpp.cms.gov, that's this website, but the one on the bottom gives you 4, 5, 6 pages of resources going into everything that you might want to report or not, and that's up to you to look at it. The only
Nothing's impossible, I have found. When my chin is on the ground, I pick myself up, dust myself off, start all over again. Don't lose your confidence if you slip. Be grateful for a pleasant trip and pick yourself up, dust yourself off, start all over again.
So basically, if you go on that website, they'll give you everything you need. They'll even tell you HSAG, the name of a company that at no cost to you will get you set up, explain it to you, help you with your computer and everything else. And that's on the website, and you can look. It's been presented to you before, so we're not going to go into detail. Now here are some other changes that are important that's starting this year and continuing from former years. Whoops. First is that local coverage determinations are more transparent. What do I mean by that? Well, there are national coverage determinations, which are set by CMS directly and usually some university, and they determine exactly what they will or won't cover in certain areas, and we'll show you what might affect you in the NCDs, and they can't be changed unless it's changed by a huge amount of time. All those decisions are usually done on a national basis, and in all those decisions, the AOA gets involved, as do other societies. The local coverage determinations are made by us. They're made by Noridian or other contractors. And we have 13 states. Of course, California is one in JE, but there's also 10 states in JF. And when we write a local coverage determination, now we have to explain in detail why we did it. We have to put the literature and explain what it means, why we wrote these policies, and they have to be sent to CMS 21 days prior to putting them up on the web. That's both good and bad. It's good because you get to know the reason for everything. It's a little bit troublesome, quite frankly, because before we had this new rule of sending to CMS, we could send it independently to people on the California Orthopaedic Association, to Diane and others, and ask for input. Now we have to put it out there all at once, so we can't have a kind of an early look by your local association. The thing about them is that all of these local rules are sent to CACs, Contractor Advisory Committees, and to an open meeting prior to each CAC. There are 3 of them every year, and there are 3 in all of our states, including California, in which this year, 2018, there'll be 2 in Los Angeles and 1 in San Francisco, both by the airport. Now, you have members from the Orthopaedic Society who sit at the CACs and comment and talk about what the policies are that affect you, or anyone else for that matter. Diane is always there, and anybody can comment. They're on the web, they're in open meetings, and all comments are answered with the explanations of why we did what we did or didn't do what we did if you want to make a change. We base all these local policies on guidelines and white papers from societies and on the literature that is available on the web, and those are usually included in the determinations. We explain it in detail, and we can explain it to you if you have any problems. But for local policies, you can always ask for changes. There's individual consideration where if a particular patient doesn't meet the rules of the LCD, you can ask for individual consideration on an appeal, and a doctor will look at it, an Iridian doctor most of the time, and give an individual consideration or not. That's particularly helpful if you want to use an off-label drug. You can explain why, give the literature, and we may often accept it. In addition, if you don't like the LCD, you can ask for reconsideration after it's final. Before it's final, you can tell us what you think about it. After it's final, you can ask for reconsideration if you submit documentation as to why it should be changed based on literature or white papers as society changes. We value your opinions. When we ask for change, please show us the data. Tell us what is or isn't the reason for it, because it's already been scoped and reviewed by orthopedists and others before it becomes final. Now, here are some national coverage decisions regarding orthopedists. You can just look at them. The more important thing is that if you go into the decision and click on it from your handout, it'll take you right to the decision where you can read it. Some of these are old, some of these are newer. They're national coverage. We have no control over them. But whether it's national or local, we'll give you the codes to use. We'll give you the diagnoses that go with the codes. And if those are there, it goes right through. So if it's reasonable and necessary and follows the coding that we tell you to do, you should have no trouble with them. Because we only review 2 in 1,000 charts. And as I said before, handouts that you have direct links to, these are the national guidelines that we can't change. The local guidelines that you can ask for an individual consideration on, and which you can ask for a change with literature, are listed here. And again, you have them in your handout, but when you have them in a handout, as you see here, there are direct links to the policy that you can read. Now, another issue you kind of have to be aware of is there are going to be new Medicare cards coming out. Uncle Sam, CMS, wants to get rid of the use of Social Security numbers because they're being stolen. They don't want fraud or identity problems. So what they're going to do is give you a new card called a Beneficiary Identifier, or a Medicare Beneficiary Identifier, and they'll start in April of 2018. They'll end in 2019, and so you have to be prepared for it. So in essence, all you have to remember is there'll be a new card coming out as early as April, and CMS is educating Medicare patients to look for the new card to prevent fraud. They're going to mail them between April 2018 and 2019. You should have your system available to take it by 2018, but keep the old numbers around because you may need to appeal. You may need to do something using the old healthcare HICA numbers, and those keep around for your safety when you change in your computer. This is what the card looks like, and you'll see in the middle for a 11-digit combination of letters and numbers, which is random to each patient, so there's no connection to the name or whatever, and that's what will base on whether the patient does or doesn't have Medicare coverage, and that will be in all of our systems starting in April, but keep the old card just in case. The next thing is a brief reminder to the office staff that starting in 2018, which is a couple weeks away, if you receive your electronic remittance advice electronically, they're going to take away paper. And for all providers who have electronic connections, you'll get everything by electronically unless there's a natural disaster. And speaking of natural disasters, for all of those who are in Northern California in the horrible fire zones, or down here in Los Angeles in the fires, and Orange County in the fire zones, and actually I was 3 blocks away from where we had to be evacuated, but thank the Lord we didn't have to. But all the people that were concerned in or around Santa Barbara and Montecito are still having a fire. For all of you who lose stuff, CMS will understand MIPS and MACRA and remits and data under these months where you may be able to explain that you've had a problem with any of your office or data. Reopenings and redeterminations will no longer be mailed. You can find them now in our Meridian Medicare portal, which is free. You just sign up for it, and you see all the information you want. You can send your claims in. You can read all about it. You can view print determination stuff. Be aware of it. We'll tell you more later. Now we're going to move into more of the clinical aspects that we hope the orthopedic surgeons, my colleagues in orthopedics, are aware of and affect them. You know, under the law, Medicare can pay for all services that are reasonable and necessary for the diagnosis and treatment of an illness or injury or to repair a damaged organ, be it a disc or a hip or a knee or what have you, shoulder. And what's reasonable and necessary, only the physician treating the patient knows what's reasonable and necessary. When you look at the patient, when you examine the patient, when you see the rotation of a joint or how much you can move it, you're the only one who knows how much the pain is, what's reasonable and necessary. We have to pay on that basis, and the only way that we can determine something is reasonable and necessary is what you've written down. And so all claims are adjudicated. Now, we look at only 2 in 1,000. So all services that you are doing and your office and your claims are being sent in by your office staff are based on codes, either CPT, which is for all offices, and some hospital codes for surgery codes use ICD-10 PCS. But most use CPT codes even for stuff done in hospital or outpatient. And all diagnosis, which you need to have, or symptoms, signs, or any reason for a service are described by ICD-10 CM codes, which is owned now. CPT is owned by the AMA, ICD-10 is owned by the World Health Organization, and CM is for this country only. Unfortunately, those of you who code in the office don't document, and those who document don't code. There is often a misconnect or a disconnect, and that's why a lot of you have, when you see them, well, you have denial.
What we've got here is failure to communicate.
So, let's move where the failure is, to electronic healthcare claims or electronic medical records. The problem is that because you have an EMR, you can push a button and have pages and pages of the same documentation. And that can be used for scoring points in an EHR. That doesn't make it reasonable and necessary. Most of your electronic health records, both the hospital and your private, tend to push you to put more things in by pushing a button, but they may not be necessary. We find electronic health records are inconsistent, incoherent, still in their infancy, doctors don't know how to code, and that's cloning. What do we mean? We'll see a record of a 68-year-old patient with chronic congestive heart failure, diabetes, renal failure, hypertension, and a fractured ankle. That's what's in the initial sentence. And then review of systems, kidney will be fine, heart will be fine, liver will be fine, but how can they be fine if you said up front that they're not fine? They can be incoherent. We can have a patient in the drug list on 6 antihypertensives and 4 diuretics. Are they really on 4 diuretics, or are they on 1 diuretic that's changed who never got rid of the old drugs? And sometimes we'll see 22 drugs in someone, many of which have changed and been taken off. They're in their infancy because they don't talk to each other. And a lot of doctors aren't comfortable with them, don't know how to update them properly. And of course, a lot of them just push the same button with the same note 8 times in a row during an office visit. What's more, you have to keep your records up to date. when you're talking about illnesses, a concurrent illness usually is something that's significant in there. I don't think it's that important to know that the appendix was removed 22 years ago, and grandma, who's been dead for 14 years, each time comes up, I don't think she'll come back to life. To review the systems will be coherent and present, and the most important part of a record is decision making. It's helpful if you listed or explained it in the chart. It's also important to note changes in care, because something that's changed or worse usually requires a higher code and a higher list. If you are doing a review, lab is helpful. A lot of words don't help, but the principles of how you're thinking do. And finally, we understand that EMRs are hard to learn. Doctors or the scribes don't often know how to handle them. And some doctors, like the one you're about to see, were very frightened when electronic records hit his hospital in Texas. This is a real doctor.
I'm sitting at the nurse's station, my ticket file, desperation. Waiting for the help desk guy to give me something I can try to get a patient list so I can finish rounds before I die. On go live night, it feels like death. On go live night. Why have I forgot my training? Why I've got to start complaining? Why care connect is draining my time and energy. My time and energy. First few days I feel like bait while super users lie in wait. They tell me that I'm learning quick, but I leave the unit feeling sick. A keyboard tutor's what I need. 4 words per minute is my key. Go live week 1, I'm in despair. Go live week 1. Week 1, at least I logged on 1. I've got to log on 1. I discharged someone, but I don't know who.
Now, many of you are starting to use scribes. And there's some rules we want to remind you about the use of scribes, particularly in the hospital or when you're with them. The history, exam, and decision making can't be performed by a scribe or anyone who doesn't have a payment benefit in the Part B, a benefit in Medicare. The physician themselves has to do the exam. Now, they can dictate something to somebody who will write it down, but the physician themselves has to perform the exam. Unless it's by a clinician, someone with clinical training, and then they have to review it. Viewing the information alone by an ancillary person like a scribe and writing, I see and agree, is inadequate. We have to have some documentation that the physician or the nurse practitioner and PA actually saw and examined the patient. So in the intent of the EM documentation, that the person who performs it and does it signs for it and write it. So the scribe does not have to sign it, but the physician has to review information as written, say, I reviewed the information, personally examined the patient, and then write and then sign their name. The scribe does not have to sign their name, but the physician has to make some notation. This was done by someone else, the typing, he reviewed it, and it's perfect. So if you see here, a physician needs to review the information, write a notation that he reviewed it for accuracy, and sign their name. What about changing a record? Now the next 2 slides are not in your handout because I added them this morning when I thought about it. late entries, addendums, you can do that. You can correct a file, particularly if we ask for it and you review it. And you say, there's a mistake here in a date, there's a mistake here in a time or something. All you have to do is, when you correct it, leave the original one, put the addendum or the change with the date you did that, and sign it when you did it. The late entry bears the current date and the person who signed it. It has to be reasonably timely. A year later is a little late, but it should bear the current date and reason for the addition. I put the wrong date on, or I aired it, or whatever. So a correction: draw a single line through the erroneous information so you could read the original entry, sign the initial date to change, explaining why, and then put in the right information, sign and date that, with the current date, time, and reason for the change. I'll leave this up for a few seconds because you don't have this, but everything else you should have in the handout. Okay, we're going to continue, so there's time to talk. Here's some E&M considerations for orthopedists. It's difficult to decide the value of thinking. What's hard for some is easy for others. But perhaps a sentence or two of how you made your decision will be a big help. The differences in one level of service, particularly E&Ms, where there are 5 possible, can be subjective. And even non-E&M, but if an orthopedist is doing spine surgery and there's an anterior, a lateral, and a posterior way of doing it, put in the right way, because you may be shortchanging yourself. They have different times, you have different amounts of payment. So be as accurate as you can to get the best reward. Understand that EMRs tend to upcode. Please review and make sure you did what you had to do. What you don't have to do, or pushing a button, may not be accurate. The overarching rule in E&Ms, whether it's done by an internist or a neurosurgeon or an orthopedist, they must be reasonable and necessary for the patient's condition during that visit, that date. So if you did a very major evaluation in the hospital to admit someone while you're trying to figure out why they have what they have, and come back a day later, it's unlikely you have to do all the same things over again. Just address the reason why they're in the hospital. Explain for each visit what is reasonable and necessary. Just don't do the docs. Medical necessity is determined through the following factors that you can read. Medical necessity involved with how much judgment you need. What are the standards of other orthopedists doing the same thing? Why the patient needs to be seen that day, the chief complaint. Anything that changes the examination, for example, an exacerbation, a new condition or injury. The stability or acuity of the patient. The older they are, if they've fallen or hurt themselves more, that may affect the surgery a little earlier. Any comorbidities, but active comorbidities, and then that date of service. What are you doing for that date of service? Now I'm going to go through quickly 2 slides. These are modifiers that surgeons and orthopedists tend to use. The only one I'm going to talk about is dash 1 or 2, but please know these are important, and you have them in your handout. 22 means that if you had a harder surgery, it takes longer because of a problem, because of an underlying problem, because of a more severe fracture, whatever, use dash 22 and explain it, and we will ask for the record and give you more money depending on how you explained that it was harder to do than the average surgery. Not all surgeries are equal, as you know. 25, I'm alerting you to the fact that some in private insurance companies, when you do something and you're examining the patient before you do it, every procedure has some element of E&M. If a patient comes to you with pain in their ankle or their knee or any place, to evaluate it before you, say, inject it, or to evaluate it before you pull fluid out of it, which are procedures, that would be a -25 because you're doing a whole evaluation of the joint and everything around it. If you're just sent a patient for a procedure and it's already been evaluated by another orthopedist or an internist, then you wouldn't be adding the 25. Now, the reason I say this is because, unfortunately, we understand Blue Cross and some of the insurance companies are cutting the E&M payment in half when you're doing it the same time or day as a procedure. We in Medicare don't do that. And as a CMA person and an AMA person and someone who wants to help my orthopedic colleagues, let's get together to make sure they stop. The other codes you can look at, understand them, and here's some more modifiers. Use them because they'll explain better your service. Remember, the only way you're explaining what you did in most claims is by putting the code in. And these codes will explain like it's a separate procedure, so pay you both separately, et cetera, et cetera. It's bilateral. They are co-surgeons. Understand and use them. Your coding team should help it. More basics. When you're doing an E&M code, as an orthopedist, what's important is the site of service, because if you put in office number 11 or hospital 21, there are different payments. Emergency room, where you do it, there are different payments, which include how much overhead there are. The type of service, a new patient is someone who you haven't seen for 3 years. Or if you're in a group practice, if another orthopedist sees him within the 3 years of subsequent. If you see the patient and then move to a different office, and you're seeing the patient still, same patient, but different office, within 3 years, it's a existing or subsequent encounter. So to be a new encounter, you have to not see the patient physically for 3 years or another member of the same specialty in your group. Now, if a family practice in your group, in a large group, sends them to you, you're separate. If a neurosurgeon sends them to you, because he says, I don't do this fine, orthopedists do, that's a separate type of physician. It's a new patient. And remember the various miscellaneous like time, care plan oversight, non-face-to-face services, which are payable. Just know that they're useful. Remember, there are 3 things in an E&M service: the history, the exam, decision-making, or time, when you spend a lot of time. If you spend time, you need to document it. But the most important part, and by documenting, put start and stop times. The most important part is decision-making. Now, sometimes doing nothing is important. So if you have a patient that has a major joint problem, the patient's old and senile, you're not likely to move, and you're thinking, is it safe to operate? They have so many comorbidities, it's not safe to operate. Can I just brace it? Should I keep them down a longer time? That's decision making. And if you do without doing anything, if you're thinking about a lot of things and there are a lot of things in the way, that's decision making without necessarily ordering or doing something major. Remember the type of patient: new or established, new patient, established. We said this already. I'm reminding you that only one visit is paid per any specialty category. So if 2 orthopedists are seeing a patient in the hospital, one goes at night, one goes in the daytime. If you're in the same office, you don't get paid twice. If you're in a different office, you have to make an arrangement. We only pay 1 orthopedist per day to see a patient. Time is in a office face-to-face time, in a hospital it's unit per floor time, at the bedside, and time to review a patient's chart, that's all included in the visit. Time off the floor, there is a code if you spend an unreasonable amount of time, and even non-face-to-face. If you have to look at a very big chart, there's a code for that, and your coders know that. And when time is used to start and stop time. What are some common causes for denials? I'm going to ask if you have these, okay? Signature. You got to sign for orders. If your office staff sees your signature on the chart and it's hard to read it, you can fix it. If it's illegible, you can have a signature sheet. This is how I sign my chart, signed Art Lerby. If it's inadequate or if it's missing particularly, you can have a attestation sheet. I saw the patient on that day, I didn't sign the note. Missing orders are very serious because you can't do something without a doctor's order. So you make sure the orders are done and signed. And digital signatures, if they're improper or missing or late, you'll be hassled or denied. Remember that you can't use a stamped signature unless you have a physical disability that we can't use hand. Labs in your office, you have to have some reason for them. Since you're not going to write an order to take your own x-ray, or you're not going to write an order to do a simple set rate or something in your office in many cases, or in a group office, you have to have somewhere in your chart that says you wanted it. It has to be obvious that you needed a film or a test, and you need an adequate diagnosis. If we find a diagnosis inappropriate for a lab, or a lab is too frequently, you're doing 3 films in the same joint every day, you may challenge it. I told you about LCDs and NCDs. We tell you the frequency, the code to use, the ICD-10 code to use both. So if you don't do it, that's a problem. Now with an LCD, you can always have an individual exception. With an off-label drug, you can have an exception and just explain it to us. If you use a drug off-label, and there are a number of newer drugs that may help, orthopedic or rheumatologic conditions that are like biologicals, give us the reason, the fact that they fail something else, literature and support. If the dose of a drug is higher than normal, tell us why, because the FDA lists what the dose ought to be. Be sure you have the right codes. If you're administering just hydration or just general keep an IV open, and make sure that self-administered drugs we don't pay for. That is something that the patient can give themselves. And you may see that frequently for rheumatologic diseases that also have a joint problem that you may be following. And then cloning, if every visit looks the same on an EMR, it'll be denied, as well as stuff that's illegible. Now let's go into a new way of reviewing, and I'm going to keep going fast so we're done on time. It's called TPE, or Targeted Appropriate Education. In fact, it's here now. We're sending out letters, and this is what the letters will look like. In order to fulfill our obligations, we're going to have to review something called TPE, Targeted Appropriate Education. There are 3 rounds. We send it to you. You have 45 days to send it back. We're going to ask you, these are where there are a lot of denials, or where if you're doing the highest number of the code more than most people. And you have 3 chances to fix it, and this is what happens. The letters are out now. You've got a letter that looks like this. And if it's a hospital, we'll say, you're doing more. Here's a chart. The last 6 months, so we're going to review it. And if you're a doctor, it'll say you have been identified as having an error rate greater than or equal to 70%, for example, or a prepayment review has been initiated, or that you're among the highest codes for highest billers, 10% or 15% for a type of service, such as an epidural. So these are prepayment before we've paid you. Now we're going to ask for the 1st, the 5th, the 9th. We won't ask for 25 in a row, because that'll be money that you're losing. Only ask for 1 or 2 at a time. After we review it, we give you education. And I'm just going to make this brief. After we get 20 to 40 charts, they'll be reviewed and sent back. And you'll get a note on every chart, every situation where there was a denial. Why, what was missing. We have webinars. You can talk to the actual reviewer as to why you were denied. You can ask for a doctor on the phone call, and we'll be there. And the denial, the numbers are based on a percent. The percent of codes that were denied versus the total percent that were paid over a time period, or a percent of money that was denied. amount of money. So here's what happens. We pick the topics, and if you're one of the highest utilizers, we'll ask for 20 to 40 claims, sometimes more in the hospital. If they all look good, compliant, thank you, goodbye, we won't bother you again. If they're non-compliant, there's a relatively high amount of denials, which can occur for not sending the records in or for not signing them right. Then you can talk to the nurse, we'll explain everything to you, we'll wait 45 days and do it again, 20 to 40. If they're fine, goodbye. If they're not fine, we do it a third time. After 3 times, if there's no significant improvement in the error rate, then you can get some nastiness. You could be sent for 100% review, prepay, or sent to the fraud unit, etc. Here are some things that might affect you that we're actually reviewing. We're looking at high-level E&Ms because the Office Inspector General noted a large increase in the higher-level E&M codes. When you admit a patient to the hospital for surgery, you're probably doing a head-to-toe exam. But the next day or 2 or 3, Grandma was dead on Monday, she's probably still dead on Thursday. You're probably only looking at the joint or results of the surgery that you had involved. You're not looking at the fundi again or involved with the blood pressure again. We're looking at epidurals and related to set joint injections, nerve blocks, or chronic pain. We're looking at those codes. We're looking at certain lab tests and imaging. The imaging may be the frequency of x-rays. And CBC is another office testing that's repetitive. That's particularly for those of you orthopedists who are in group practices with other specialties. We're looking specifically at denosumab because as Prolia, the lower dose, it's used frequently in osteoporosis that are often with pain and bone problems, or in bone cancer, which may be dealt with by orthopedists as well as oncologists. We're looking at rituximab, which is used in a number of situations off-label. We're looking at complex chronic care management codes, which suddenly everybody is using, and so be careful if you're using them. We're looking at selective biologic drugs, prolonged E&M codes 99354, some SNF cases, as orthopedists sometimes follow their patients SNF, ER visits, and some physical therapy, which, again, some orthopedists do in their office. That's what we're actually looking at. So we're not looking at that many orthopedic records other than joint problems, epidurals, but we are looking at the E&M. Who can ask for records? And we only have about 4 or 5 minutes left, so there'll be time for questions. We can look for it with Medicare administrators, the error rate people, CERT. That's an advanced med. You'll get an envelope that looks like a publisher's clearinghouse envelope asking for a single chart. Please send it back. We would be asking either prepay or postpay, Iridian. You also can get records from Safeguard. They're the benefit integrity, otherwise known as a fraud contractor. I would advise you to really send back. Most of the people who get those are when a patient says, I never saw the doctor, and it's not infrequent for elderly, confused patients or their family who weren't there to say that the patient never went to you. Just send back a record. These people, the SMRCs, can do it. They're called, the company is Strategic Health Solutions. Recovery audit people, the RACs, Health Data Insights is one of their names. The OIG can ask, and of course, Department of Justice, which is rare. You certainly want to, and then of course, private insurance. How to fight back.
So, I want you to get up now. I want all of you to get up out of your chairs. I want you to get up right now and go to the window, open it, and stick your head out and yell, I'm as mad as hell, and I'm not going to take this anymore.
Because all those people are looking at you. Okay, how to fight back. When you are asked for a record, have a set process for dealing with them. What do I mean? When you have a new patient, what do? Well, first you take the name and address, take the insurance, copy the insurance card, find out who's responsible or who their next of kin is. You're probably going to have a form filled out that they sign and understand what happened to their records. You may have a form filled out about their past history and their drugs. Then you make a chart up, put the chart in the door, and you go in. That's a process you have. And you have other processes. We'll have one for responding to records. have one office person or two, the same one sent again, so they're used to doing it, someone who knows you and knows something clinical. Have a checkoff sheet. Is it legible? If not, you can retype or print as an addendum. Is it the right name of the patient, the right doctor, the right date? A lot of patients that you have in a busy office have similar names, similar Jones, Smith, White, Black, similar Hispanic names or Asian names. Make sure you're signed where it ought to be. And the office should see if there's no signature, put an attestation or signature sheet. If it's not legible, fix it. Make sure it's the right name. Send it to people who asks for it. Because if we get something we didn't ask for, it'll go in a circular file. We have no idea who else is asking a record. Do it within a time frame. Know how to get hospital records, and please send it by certified mail so you know, because everybody makes mistakes and loses things. If it's certified, you're covered. Who can you fight back when they ask you for money back? Or we're the first person who looks at your claim for $1 or more. That's when you send the claim in. If you don't like what we did, denial, you can ask to look again. You have 120 days, and all you need is that one claim, or as many as you want. It'll be looked at by a higher level nurse or even a doctor. If you don't like what we do, you can send it to a qualified independent contractor. You have 6 months to file. And each denial has a list and the name and the address of where to send it, and also the reason it was denied. If you don't like that, you can go to an ALJ. You need only $160 putting all your files together. You have 60 days to file, and they often look favorable as the doctors, unless us. You can go above that, but it's not likely you will. Hospitals do that. Send it, and don't fear. Nothing will happen. Now, coming from CMS is good news. They want to make documentation easier. It's a new program signed by Verna Sema, the new head of CMS, all the way through, and they're finding ways to make life better. What do they want to do? Well, they want to have make 8 to 10 things easier or eliminate some of the requirements. The first one, they want to make signatures easier, and they're looking for other things to do, and they're asking us, and they'll be asking you. So I hope that Diane or others from the COA will respond when they ask, how can we reduce provider burden and inappropriate appeals? They want things to be standardized, so our policies will look more similar across the country. They want to look at or vet existing requirements, getting your feedback, looking ways to make life easier. So CMS, AOA, everyone's going to try to respond.
You gotta come back with me. Where? Back to the future.
Here's some upcoming trends to be aware of, and I'll go fast. There are in-store clinics at some Target with Kaiser's. Providence, which is a big system in Southern California, are trying to have an NP virtual system called Healthcare Express. Walgreens and MD Live, you can call up on a phone for a price in some areas and speak to a nurse practitioner. There are telemedicine kiosks around large companies because they find it's convenient to have patients check out their health before they spend a day off at the doctor's office. People, social media, are talking about you in your office, and there's a lot of alternative medicine. Now, in the interest of time, I'm going to skip this, but what else is happening? Changes in lifestyle. More doctors coming to training want to be hired. They don't want to be in offices. There's problem with entrepreneurship. We're using a lot more non-physician practitioners. To some, it's a big help. To others, it's not a big help. Depends how good they are and what they cost. There's tremendous consolidation. Everybody is merging. Hospitals, university groups, doctor groups, big pharma. Doctors' practice are being purchased by big groups, and then the doctor works part-time. Who's going to big business is getting involved, which makes it difficult. So what's the outcome for healthcare? Well, you can look and see, is it going to be single payer, as some people talk about? I don't think so. I think more, if you want my personal opinion, of a British system in which private insurance for those, hit the wrong button. I'm sorry. Where there'll be some kind of a national program, and people can buy insurance on the side and go to their own doctor when they want to. We have the mishmash muddle right now, everything, state, local, national, private. Some smaller practices are opting out of everything and being a cash only or a concierge. Some small practices are merging or becoming virtual practices. Look around. People are quitting and coming into jobs like I do, alternative administrative medicine, and everyone is going to artificial intelligence is also taking off. Let's take a look at this. Working together as orthopedists, as physicians, as larger groups, we can improve our office procedures for the benefit of our patients, our staff.
When you're weary, when you're feeling small, when tears are in your eyes, I will dry them all. I'm on your side. All time get round, and foes just can't be found like a bridge over troubled water. I will lay me down.
Okay, time for questions, and we started about 8 minutes late, so I'll do as many as I can. Shall we open up the mics? Hello?
Hi, Dr. Lurvy. So if attendees have questions, they can unmute themselves and ask them one by one.
That's fine. I'll stay a little longer if people have more questions, but we did it 4 minutes over. Sorry. Do we have questions? I don't hear anything.
If you're having trouble unmuting yourself next to your name, click the microphone to give yourself the option to speak.
Also, if you have a question, if you send them to COA, I will answer them by email if you think of something later when you look at the slides. So if you're embarrassed to ask a question now, some people are, feel free to write it and we'll give you an answer in writing.
if attendees could also use the chat box in the right-hand panel.
I'll see if I can read the chat box. I'll click this. Okay, I'm looking for the chat box. Oh, here's the chat. What's chat? Click on chat box.
I have access to it. It doesn't look like anyone's including any questions. So at this time, if you want to conclude,
Yes.
I will be sent.
I'm going to remind people that my last slide has my email and my ugly picture, and you can send any question. You may find the answer in the handouts. We went fast, and I understand that, but there's a lot I wanted to mention. And possibly for those who go to the COA meeting in the summer, depending on the company and everything else, perhaps I can be there. And usually if I'm there, I sit at a desk for an hour or two and answer them one by one then too. So you have access to whoever you need.
Dr. Lervy, we do have one question submitted.
Sure.
What is the time frame when there is an audit, when you're audited?
It depends what you mean by audit. TPE, the new program, we're asking for records now based on data. We get data. And the data shows where California is greater in certain codes, in certain usage than other states. And the general feeling that CMS has is that, you know, we're a general population, although there are differences in age and background and all kinds of things, that basically the number of something per 1,000 patients should be similar across different states. And so if we're markedly different than we're told, and we look at the highest users of those codes, and a letter will go out saying, let's say epidurals, and if a couple of people are doing on the same patient epidural every month, which we think is somewhat dangerous, and so that means more epidurals by Dr. A than Dr. B, we'll ask for 25 charts. Now, if we look at 25 charts and say they're all correct, goodbye. When are we doing it? We're doing it now. We're doing it gradually. We don't look at that many people, and we're not looking at that many orthopedic things. But you'll be asked for records. You'll get the letter first that says we're going to be asking you for 20 records or so, and then every fifth or sixth of that code, we may ask you for that record. You'll know about it ahead of time. And you can always ask questions. So that's it. That's that audit. Other audits may be done by other people for other reasons. In other words, private insurance do audits. There's maybe audits of a hospital that involves a doctor. So, I mean, when are they coming? They're constantly coming slowly. The new system is already, letters going out, so you may not have gotten the letter yet. We don't look at that many. Most of you will probably not get an audit. Most of the people in California, with some very rare exceptions, are pretty good orthopedic surgeons and pretty good offices that are doing the right thing.
Dr. Lervy, they were wondering if it's a 1 to 3 years time frame.
No, the audits are when they start. After the first audit, you're done for a year if everything's okay. But if it's not okay, we wait 45 days for you to be educated, to listen to us tell you what's right or wrong. Do it again. If you drop from 70% denial to 40% denial, we say very, very good. We'll look again after 45 days. And there are 3 sets of 45-day periods. So you're asked for records, then we take maybe a month to review them. Then we tell you the results, and we'll do it, live with your office. Then there's 45 days where you can correct anything or look sharper or put better documentation. We do it again, but it's slow, and it's not that many. We don't want to tie up that many charts with that much money for anybody since it's prepaid. Now, other people, the RACs do their thing, the SMRCs do their thing. I showed you all of those people. They can also ask for records, which is why you should have a process in place for records. We don't ask for that many. I haven't seen that many orthopedic things looked at, and I showed you what we're looking at right now. Now, things can change. and there are not that many orthopedic things that we're looking at.
Okay, so it's 1:32. I do have 2 more questions submitted, so we'll go with those and the webinar. The next question for you is, when do we stop using the old HCIN numbers for claims and appeal submissions?
Right. It's HICN, Hicken. But the answer is, starting in April, people will get new Medicare cards with that new number, the Medicare beneficiary number, MBM. And when they have that, that's when you start using it. But there'll be a year when you can use either or both, either one or the other. But the patient, if they destroy the Medicare card, may not keep the number. So you keep it. Keep both numbers just in case you have to appeal something over time or find something wrong or someone challenges you. It starts in April 2018, and they claim they'll finish Medicare cards by April 2019. That can change. Anything can change. This is what we know now. What's the next question?
Okay, the next question reads, can orthopedic physician use the ER/EM codes when seeing a patient in the ER? They're hoping to get this in writing to be able to show their practice. So where can I find this resource?
Actually, usually orthopedic doctors write the ER code. There is a code. Let me think. Yes, you can use the emergency room code. Send me an email to that effect, and I will double check to be sure. My understanding is there is a code for seeing people in the ER, and if the ER doc is not an orthopedist, then you both should be able to bill. But I will double check and give it to you. If you send that to me by the email, I'll put it in writing. I'll check it first to be sure, though.
Okay, it looks like we have
the other thing I think I should check, and you should too, is look at the payment for an ER visit versus a consultation or a high-level visit. See which one pays better. You might as well take the one that pays better.
All right, Dr. Larry, I believe that's all the time we have. There are a couple questions that came through that I will be sending off your way. But I do want to thank everyone else for joining us today for this presentation. It was recorded and will be available on our website in a few days. I also will be sending out an email with all the attachments, Dr. Larry's contact information, as well as the audio file. So if you have any questions, you can email him directly. And we hope to see you next time at the next COA webinar. Dr. Larry, you have any final remarks?
Just want to thank all the people who were there. I'm going to ask you if you could send me a note of the number of people or offices that were involved so I could record it for our purposes to show CMS. And please look at either Noridian or other sites, the COA or AOA, because things change. We're in a time of healthcare change, both clinically and governmentally. So please stay up to date with changes. You can go to our website, which is listed. You can certainly do it off COA. In fact, I have looked at many times at the COA website, and it's a very good website, and they'll keep you informed, just so you're up to date on everything and able to do things right. And remember that new CPT codes, not that many, but some, are coming out January 1.
All right, everyone, have a great day.
Thank you, everybody.